Dr. Yasser, I started recording.
Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And today we are indeed with critical care nephrology topics. I will speak about volume management in critical ill settings or in acute settings. Before I start, I want to introduce the moderator today, our great moderator, who is Professor Amr al-Husseini. Professor Amr al-Husseini, one of Egyptian scientists in USA. He is a professor of nephrology and medicine in University of Kentucky in USA and medical director. Professor Amr took his MPCCH from Mansoura University, and he is usually every now and then is sharing his mother university in its scientific activities regarding CME activities, and every now and then we can find Professor Amr sharing us with his great experience in our CME activities.
So much, Professor Yasser. I'm thrilled to introduce today.
Please, Professor Amr, if we think my sound is good like this.
Yeah, it's good. It's good.
I can see some complaints. I can see some complaints from this, and
I hear you very well.
I'm trying to manage. It's good.
Yes.
Okay. So if you search for Professor Amr al-Husseini on PubMed, you will find that he has more than 110 or even 120 publications in many fields of medicine in his fields of interest, including CK MPD, including GN especially, and including kidney transplantation and critical care nephrology. Professor Amr is the vice president of the World Kidney Academy, and he is the director of glomerulonephritis course, which is running nowadays, and he is the CKD MPD course, which was running a few weeks ago, and we can see students graduated from this course now. So I am honored today to have Professor Amr as the moderator, and we can expect his experience to add so much to my lecture. And I will leave him the floor and come to you back again to give the lecture. Hope to be to that level. Thank you. Please, Professor Amr.
Thank you so much, Professor Yasser, for the nice introduction. I'm thrilled to introduce one of the distinguished speakers, especially in critical care nephrology, Professor Yasser Abdelhamid, professor at Cairo University. He is interested in critical care nephrology and AKI, is currently the head of AKI team in his institution that's accredited by the European Society of Intensive Care Medicine. He co-authored many guidelines and manuscripts, especially guidelines in dialysis and AKI, nationally and internationally, and also with the plasma exchange. He's a section head for the CME, Egyptian Society of Nephrology national guidelines, and also he is on charge of the e-learning for his national society. He has many publications in the field of nephrology and critical care medicine. Moreover, he is co-directing a critical care nephrology program with me. We are structuring it, and we have been meeting, and we structured the board, and hopefully you can have the chance to see the achievements and the progress in this fellowship within the incoming months. And I'm going to open the scientific meeting today with one case of volume overload, and I would like to invite all of you to think about this patient, which is very, very common. We see almost in our daily practice. This is a 56-year-old patient who were admitted to the hospital with worsening dyspnea, and he gained 8 kilograms in the last couple of weeks. He has a history of acute decompensated heart failure, type 2 diabetes and hypertension, along with coronary artery disease and CKD stage 3B, on top of ischemic cardiomyopathy with low ejection fraction of 30%. He's adherent to his medications, and he's taking losartan, furosemide 40 milligram twice, atorvastatin, and insulin. His blood sugar is well controlled. However, his blood pressure is high, 162/92 in the hospital. His heart rate is 104. Physical examination showed S3 gallop, bilateral crackles, and 3+ edema. Admission lab showed serum sodium of 132, serum potassium 5.2, BUN 63, and his serum creatinine increased from a baseline of 1.4 to 2.1. Very common case scenario that we are facing every day in our practice. And now the question is, which of the following is the best next treatment or step in this patient management? So this patient with CKD, congestive heart failure, diabetes, hypertension, was admitted with volume overload, and he was on Lasix oral with ARBs and statins. And now what would you want to do? Start furosemide IV infusion, or start metolazone, or dapagliflozin, or start dialysis with ultrafiltration, or pure ultrafiltration without dialysis, or discontinue losartan. So these are the 5 options. Please put in the chat the best approach for this patient. Then, same patient, after he received Lasix and started IV doses of Lasix infusion, 5 milligram per hour, his urine output has increased to 2.4. After 2 days of admission, his dyspnea and volume overload has improved, blood pressure is down, and his urine output is about 2 to 3 liters. And his creatinine went down to around his baseline from 2.1 to 1.7. Now, the patient wants to go home, and we are preparing the patient for discharge. We switched his IV diuretic to oral, and now the question is, what dose of diuretic you would like to discharge the patient on? Would you like to discharge the patient on furosemide 120 milligram twice a day, along with metolazone 10 milligram? Would you like to switch IV furosemide infusion to oral 80 milligram twice daily, or 160 milligram daily, or switch furosemide to bumetanide 4 milligram twice daily, or bumetanide 4 milligram daily? I will leave you with these 2 questions to think about. Again, very common scenario. We have to make sure that we are on the same page in managing our patients. And for the sake of the time, I'm going to stop my share here, and I will let Dr. Yasser Abdelhamid to start his presentation. I'm very sure that all of us will learn. And also we have Professor Hisham Sayed, the professor of nephrology at Ain Shams University. And of course, we are going to learn from him and from Dr. Yasser. So again, I'm highly interested and thrilled to have both of them, and also to have all of you attending our meeting. And here, Dr. Yasser Abdelhamid is going to give us the basis and advanced management of volume issues in critically ill patients.
Thank you, Professor Amr, for your very kind and nice introduction and for this case, which is really a very good start to our meeting. Can you see my slides?
Yes, go ahead, please.
Okay. My talk today is about volume management in critical settings or in acute settings. And here is, that is my agenda today. And I can think this is an important question. To fill or not to fill, this is to be faced when we faced with this dilemma with intravascular volume and how. Is this intravascular volume really needs to be filled or not to be filled? So this question will lead us to what are the consequences of volume overload? Is it harmful to overfill the patient? And the second question is it really filled or underfilled? And the third question will be how to fill if the patient is underfilled, including eye fluid therapy. And the last question is if the patient is well filled and overfilled really, do we need, how can manage this and by diuretic therapy? And this would include, this would constitute my agenda today. And let we start by the first issue, which is consequences of volume overload. As we usually say, the commonest intervention in hospitalized patient and the commonest drug really to be taken in hospital is fluid therapy. So fluid therapy is considered as drugs. In critically ill patients, adequate fluid resuscitation is essential, as we all know, to restoration of cardiac output and for the maintenance of blood pressure and essential perfusion and organ perfusion and renal perfusion. So in this study in Indian Journal of Critical Care Medicine 2020, it was associated with increased volume overload, was associated with increased morbidity and mortality, and increased length of hospital stay, and increased risk of acute kidney injury. So this is the main study or one of the major landmark studies regarding the effect of volume overload. Is it really harmful or not? And studied the effect of fluid accumulation on the survival, recovery of kidney function in critically ill patients with acute kidney injury, and was in 2009 in Kidney International. You can see that patients with a probability of survival is higher in patients with no fluid overload, and even in patients both dialyzed and non-dialyzed patients. Also, percent of mortality is higher with weight gain 1 to 10, 11 to 20, and more than 20 pounds weight gain in both dialyzed and non-dialyzed patients. Percent of mortality increases with percent of dialysis days with volume overload. As we go more with volume overload, we can, in dialysis, we can expect a higher mortality. Also, even in patients with intermittent hemodialysis and CRRT, you can say that dialysis days, fluid accumulation is lower in CRRT patient relevant to patients on intermittent hemodialysis. Another study later on in Critical Care Journal 2015 found that cumulative fluid balance survivors, non-survivors higher. This is the non-survivors higher, of course, with increased incidence of cumulative fluid balance than survivors. So it is a harmful thing to leave the patient with volume overload, not simply dyspnea, not simply inability to sleep, and it is not simply clinical, it is also a mortality, had a mortality effect. And this is simply the mechanism: excess fluid or distributive shock or cardiogenic shock, both results in increased lymphatic drainage, and this results in decreased arterial perfusion, decreased venous return, tissue hypoxia, and interstitial edema. Both results in AKI. And this is a vicious circle. AKI leads more and more fluid load, volume overload, interstitial edema, more and more edema, more and more AKI through these three mechanisms. And you are really familiar with that. The worst thing in medicine is to go into a vicious circle. You don't know how or where to cut this circle, to cut it short. So first part of my talk, lapsed, that it is a harmful effect leaving the patient with volume overload. Coming to the second question, is it fault really? And this will lead us to the assessment of volume overload. Assessment of volume overload, what are the methods to assess volume overload? We can assess volume overload as we all know through clinical symptoms and signs, which had variable sensitivity and specificity, which we usually do every day now, and through chest X-rays and then familiar findings we all about, and using of natriuretic peptides, which are good negative in diagnosing volume overload, not really good positive. Bioimpedance, which is more can be used in chronic settings, but can be used in acute settings. And I will go rapidly one by one to come to our core of our lecture today. About clinical status, we can assess the daily fluid balance and the cumulative fluid balance, which includes the whole stays, hospital stays fluid balance, not the day-by-day fluid balance. And fluid accumulation, fluid overload, how much this patient is overloaded is from his baseline, and the percent of fluid overload adjusted for body weight, which can be calculated simply by the total fluid in minus the total fluid out divided by the admission body weight. Simply, it is a percentage of the amount of fluid the patient gains in relation to his body weight by multiplied by 1%. If we found this, more than 10%, we can expect that the patient is having volume overload that can impact his prognosis and impact his clinical status. Regarding the levels of pre-natriuretic peptide, we can face, unfortunately, pre-natriuretic peptide is used mainly high levels, markedly increased more than 500 in decompensated heart failure, in patients with pulmonary hypertension, in patients with acute pulmonary embolism, and in patients with septic shock. And as you can see, these are all our patients. So we can expect a increased level of PMP in near all of our patients, irrespective of, or somewhat not that much related to their volume status. It is also decreased in obesity, and most of our patients are obese, and drugs, ACE inhibitors, beta blockers, spironolactone, and diuretics. These are ICU drugs. I think most of the patient, if not all the patients, are using these drugs. So these are the causes of decrease, and these are the causes of marked increased levels. So you can expect that this level has many variations in case of acute settings, and you cannot depend to that much degree. So this is the cause behind my what I have mentioned before, that it is a good negative. You cannot depend that it is a good positive for assessment of degree of volume overload. Regarding bioimpedance, it can calculate soft tissue hydration, 2 to 3% measurement error, just it, and the agreement between it and central venous pressure indications was good in high CVP groups, moderate in medium CVP groups, and poor in low CVP groups. So in these patients with poor CVP, low CVP, the agreement between bioimpedance is low. So combination of peripheral tissue hydration and central venous pressure, particularly in those with low CVP. And all of these methods, you can, the best way is to combine these methods together, in addition, of course, to clinical picture, in spite of being that variable sensitivity, to assess that the patient is really volume overloaded or volume depleted. The second coming is Doppler, which is gaining more focus today, is the use of Doppler echocardiography and Doppler ultrasound, and the POCUS, point of care ultrasonography. And these are the chest X-ray. You can find the same B lines which you can found in chest X-ray. You can found these P lines on ultrasonography, and by the number of P lines, you can assess the degree of volume overload. Specific sign is comet tail sign found on the ultrasonography. Assessment of very important is IVC diameter and collapsibility. And this is the normal expected IVC diameter to be between 1.2 to 1.7, and it is dilated from 1.7 to 2.5, and more than 2.5, it can be considered severely dilated. So assessment also of collapsibility of inferior vena cava or IVC is important in addition to its diameter to see if the patient is filled and low collapsibility or vice versa. Also assessment of right ventricular diameter in addition to as a measurement of echocardiography findings. And we can have some of our experts and some sessions. We have, I think, Mu'taz Fathi addressed this issue in a previous session before in this platform. This is the picture of P lines, and this is the picture of pleural effusion in ultrasonography, liver, and this is spine, and this is pleural effusion in ultrasonography. Focus. Point of kill ultrasonography now can be connected, and you don't need to have ultrasonographic apparatus beside the patient and to transfer the apparatus or transfer the patient to the site of apparatus. You can do it simply using your mobile and the probe, and you can carry the probe, a portable probe, and do chest ultrasonography as we can see in this method, and bedside assessment of volume overload and chest conditions. And we are expecting more and more focus workshops to be running in days to aid all clinicians to have this technology in their hands and to use in assessment bedside of volume overload and other things, including, for example, pleural effusion, as you saw in the picture. So we finish this and finish this, and these are, I think these are good news, but we are going to the most, or the two important things, how to fill, including fluid therapy and diuretic therapy. The third question is how to fill, including diuretic fluid therapy, and I will depend on the coming slide regarding this point on the 2021 Surviving Sepsis Guidelines for Management of Patients with Sepsis as a classical example of critically ill patient and patient with, of course, sepsis-induced acute kidney injury. They recommended that for patients with sepsis-induced hypoperfusion or septic shock, suggest that at least 30 milliliters per kg of IV crystalloid fluid should be given within the first 3 hours of resuscitation for assessment of the response, and at least primary bolus for resuscitation. Coming to the important question, which crystalloids to use? We are to use 30 milligram per kg, but which one? This is the history. In 2015, split trial said that no difference between that saline and balanced solutions in the development of acute kidney injury. The story became different in 2018 by SMART trial, which found that use of balanced crystalloids resulted in lower rates of composite outcomes of death from any cause, new renal replacement therapy, or persistent renal dysfunction. By 2019, secondary analysis of the same study found that among patients with sepsis, specifically for patients with sepsis, use of balanced crystalloid was associated with a lower 30 days mortality compared with the use of saline. So the guidelines recommended that, suggest using balanced crystalloids instead of normal saline for resuscitation, although it is a weak evidence. There is, of course, we can expect that most of the recommendations will be weak evidence due to the low number of patients with sepsis and low number of critically ill patients that we can depend upon for our guidelines. There is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with septic and septic shock who still have signs of hypoperfusion and volume depletion after initial volume depletion. So we can use liberal fluid intake or restrictive fluid intake. We can use fluids, except in cases conservative strategy is also is specifically recommended in patients with sepsis-induced ARDS who do not have evidence of tissue hypoperfusion, and they recommended this in their guidelines since 2016 and extended to the guidelines of 2021. Albumin suggested to be used in a more weak and moderate quality of evidence in patients who received large volume of crystalloids and still hypoperfused. Regarding monitoring on vasopressors, they recommended that in the strong evidence, recommended initial target of mean arterial blood pressure of 65 millimeter mercury over higher mean arterial blood pressure targets. So we are to target mean arterial blood pressure of 65 millimeter mercury. Guiding resuscitation to decrease serum lactate in patients with elevated lactate levels over not using serum lactate. So please remember to use serum lactate whenever it is available. What about monitoring using of dynamic measures to guide our fluid resuscitation, not depending on physical examination or static parameters alone? What are these dynamic levels? This includes levels depending on echocardiography, such as a response of passive lead raising test or a fluid bolus, and their assessment of response on the stroke volume variation, and assessment of pulse pressure variation. And of course, we can assess also ultrasonography and the IVC or can assess right ventricular diameter. But to be remembered that traditional hemodynamic measurements such as CVP are no longer recommended, even the trend of CVP. So please remember this, traditional CVP is no longer recommended. And you can all know and that CVP, many patients having ascites, many patients having pleural effusion, many patients having are having tricuspid regurg. So CVP is considered as completely or totally inaccurate measure in assessment of response to fluid overload. So please use these dynamic measures. These are recommended to be used in our monitor. We suggest using this clinical method, including capillary refill time to guide resuscitation in an adjunct other measures of perfusion. So the only clinical method recommended to be used is capillary refill time, although also on a weak evidence. Recommended resuscitation goals or endpoints, as I have mentioned, is mean arterial blood pressure more than 65 millimeter mercury. Again, normalization of serum lactate. Please remember to use serum lactates. And dynamic measurement indicates that the patient is no longer fluid responsive. So patients, please, these are the three measures: mean arterial blood pressure, normalization of serum lactate, and dynamic measurement to be used more than static measurement. Regarding bicarbonate therapy, hypoperfusion-induced lactic acidemia against the use of sodium bicarbonate to improve hemodynamics or to reduce vasopressor requirements. In lactic acidemia, against the use. Severe metabolic acidosis due to AKI, stage 2 or 3 ACAN, we suggest you can use serum bicarbonate therapy in this stage. So avoid in lactic acidemia, and you can use in cases of AKI, ACAN 2 or 3. These are our IV fluids and how can they be manipulated in the intravascular and the body compartment. Glucose 5% mainly intracellular, to a lesser extent extracellular fluids, and lesser extent in the plasma, while saline is mainly extracellular volume and not intracellularly, is mainly restored in the intracellular compartment in addition to the plasma, while plasma and colloids and blood are mainly resides in the vascular compartment or the plasma compartment of body fluid compartment. These are the NICE guidelines, and I will leave it to you for resuscitation. I think it is more complex to be illustrated in this lecture, but this is what I want to stress upon in this slide, that normal daily fluid and electrolyte requirements are 25 to 30 milliliter per kg per day water, 1 kg per day sodium, potassium, and chloride, 5 to 100 grams per day glucose. These are our requirements needed every day according to these guidelines 2007. What isotonic fluid to be used in which situation? 0.9 saline, shock, resuscitation, fluid challenges, and lactated ringer or balanced solution, dehydration, burns, GIT fluid loss, acute blood loss, and in hypovolemia, while D5 in fluid loss in dehydration, but I am not with this statement largely in patients with, especially patients with hypernatremia, as hypotonic solution, and solution become hypotonic when dextrose is metabolized, as you all know, in cases of hypotonic solution, in cases of hypertonic conditions such as hypernatremia. These are the IV fluids composition. This is the composition of human plasma, including sodium, potassium, calcium, magnesium chloride, and osmolarity. This is the normal saline. You can see that it is having higher sodium, potassium 0, calcium 0, magnesium, and the chloride, of course, you know that it is a high chloride with risk of hyperchloremic acidosis, much high osmolarity than the plasma. And these are the balanced solution, including lactated ringer, plasma light, normal light. And you can see these are closer to the plasma osmolarity than the difference between normal saline. And the one is plasma light, which is nearly close, very close to the composition of human plasma. And Professor Amr can tell us after the end of this story, of this lecture, about his experience in the use of plasma light and normazole, as we are in Egypt not that familiar with these two solutions. This is plasma. The third, or sorry, the fourth part of my talk will include, in cases of volume overload, how to manipulate this case. And this will include two parts. And this will aid you, I think, hopefully, sorry for this. This will help you in the case scenario Professor Am gave you in the start of this lecture, hope to be of benefit to solve this clinical dilemma. Starting with diuretics. Most of the diuretics act through sodium, preventing sodium reabsorption, and in this case, sodium attracts water and comes out with water in urine. This is nearly the same mechanisms of all diuretics, with variation of the carriers, variation of the site of action, and etc. But this is nearly the same principle, except mannitol, which acts by its osmotic gradient. This is a general idea. Mainly transporter on the luminal surface, and this is of importance that in cases of low GFR, we need higher doses of diuretics, such as loop diuretics, for example. So they act lumen and needs good GFR. And if GFR is not that working, you are to increase the dose of diuretics to overcome this default, except aldosterone receptor antagonist, which acts through the basolateral surface. Simply, these are sites of action of diuretics. Here's acetazolamide proximal tubules, osmotic diuresis mannitol. Loop diuretics acts here late loop of Henle. Thiazides, early distal tubule, aldosterone antagonist, spironolactone, and the potassium sparing diuretics acts on late distal tubules and early collecting ducts. Loop thiazide acetazolamides are acidic, so they act through organic acid pathway, while amiloride, trimethylene are organic bases, act through the organic base secretory mechanisms. Let we go to our business in acute settings, which are mainly loop diuretics. We are not concerned that with the diuretics acting chronically, such as thiazide diuretics, for example, but we are to stress on loop diuretics. And I will take thiazide from thiazides, what's called thiazide-like diuretics, and use it in some coming slides. Loop diuretics, as you all know, furosemide, torsemide, and bumetanide. And these are arranged in the terms of potency. Torsemide first, bumetanide, and the one we are all familiar with, furosemide, is the least potent of these three drugs. Roughly 40 millimeter of furosemide is equivalent to 10 millimeter of torsemide and 1 millimeter of bumetanide. When maximally effective, loop leads to preventing the absorption of 20% of filtered sodium. About 200 to 550 millimole of sodium is expected to be excreted in 3 to 4 liters of urine in 3 to 4 hours, which are the hours of action of the diuretic. These are the 3 loop diuretics. Please remember that furosemide is affected by furomethanide do so, but furosemide not. Only furosemide is renal metabolized, while torsemide and furomethanide are hepatically metabolized. Regarding the sealing effect of diuretic, and this effect of intravenous and oral in cases of a heart failure and cases of normal patients. High doses above the maximum effect of diuretics will increase the risk of side effects. So avoid reaching these high doses results in exposure to high side effects. To induce further diuresis by these high doses, we can expect to inject the diuretic more frequently or give it as a continuous intravenous infusion after a bolus infusion, as we will see in the coming slides. This is the half-life. You can see that torsemide is the prolonged one, then furosemide and furomethanide, and we are expecting from torsemide to act longer than furosemide in our clinical practice. Oral intake, furosemide start by 20 to 40 milligram per day. Maximal single dose of patient is recommended to be normal kidney function is 80, to be increased up to 240 to 60 100 milligram in a single dose in patients with impaired kidney function. While torsemide 5 to 10, up to 20 milligram per day, furomethanide at a starting dose of 0.5 to 1 and can be increased to maximum dose of 10 milligram per day. The duration of action is important to space your doses or to give the second dose. Furosemide 6 to 8 hours. Torsemide can be extended to 16 hours, while furomethanide 4 to 6 hours. Sorry, furosemide is 6 to 8 hours. What about IV infusion? This point is important. Before starting or changing to higher infusion rate, inject a dose of respective diuretic intravenous. It is difficult to expect a response from IV infusion if the patient does not give a response on this bolus. So your bolus treatment or your bolus dose is a test dose that what will be the condition of a patient with IV infusion. These are recommended IV loading or test doses: furosemide 40, furomethanide 1, and torsemide is 20 milligrams. Regarding the dose of infusion, in patient with normal serum creatinine, nearly normal, more than 75, furosemide 10 milligram per hour, furomethanide 0.5, and torsemide 5, while to be increased 10 to 20, furosemide per hour, and 10 milligram for torsemide, and more increase with drop of GFR to 40 milligram per hour or 2 per hour for furomethanide or torsemide, up to 20 milligram per hour infusion to fight the effect that I have said they are act through the luminal receptors, not from the basolateral part. Unfortunately, with more and more diuresis, activation of tubular feedback with the less sodium to decrease to reach the macula densa. This results in what we call the braking phenomenon of diuretics, which is decrease of natriuretic and volume contraction, decrease of natriuretic effect of furosemide with time as we approach volume contraction. This is due to activation of glomerulotubular feedback with subsequent activation of sympathetic nervous system, renal aldosterone system, increased renal remodeling, extracellular vascular contraction, and decrease of GFR. And you can expect more and more with volume contraction and more with diuretic dose, decrease of natriuretic effects and decrease of their diuretic effect with time. So use diuretics, don't reach to the point that your diuretics need to be no more effective at the point of volume contraction. I really didn't know about the scenario of Professor Amr, but I will illustrate the cases of an acute decompensated heart failure, which was the case in the coming slides, and help you in the scenario. This is the major dose trial published in New England Journal of Medicine about the effect of intravenous infusion or continuous bolus or continuous intravenous infusion of diuretics. This is the question. Use of urimizumab and the use of low versus high dose. And they studied the effect of the score of symptomatology and global clinical score. You can see that nearly continuous and intravenous, the same area under the curve of this global score assessment, clinical assessment. And low dose and high dose is a slightly better score, but it was not that significant. It is non-significant effect. This is the change of serum creatinine, bolus, continuous intravenous infusion. You can see that more change with continuous infusion, but was non-significant. And low dose, the same, higher change with higher doses of furosemide, but was not significant. Also, all secondary endpoints, including AUC dyspnea, freedom from congestion, change in weight, net fluid loss, and all of secondary, even natriuretic peptides, all were non-significant difference between continuous and bolus infusion regarding low dose and high dose. The only difference was found in AUC for dyspnea at 72, higher dose, better improvement significantly, and change in weight, more weight reduction by the use of high dose, and net fluid loss, of course, by the higher doses, which were significant effects. And you can expect this from our clinical practice. This is the recommended by this study, this stepped care approach. If previous oral dose was less than 80, the bolus 40, and infusion rate was 5 milligram. Oral dose, no added metolazone. If previous oral dose up to 160, the bolus is 80 and infusion 10. Here to add 5 milligram metolazone and up to 240. Furosemide bolus 80 and infusion 20, more than 240. Again, these are the readings, and these are the recommended of combined diuretic therapy, which I will mention later on, of metolazone. What to add to diuretics? Many trials, vasopressin antagonists, Everest trial, of course, dopamine, not for treatment of AKI, but as an add-on for diuretics, in both varying acute heart failure trial, and higher dose of spironolactone ethine heart failure trials with varying effects. And it's important to differentiate intravascular volume. Is it really overfilled and we need only diuretics, and or underfilled and we need albumin plus or minus diuretics? We are to differentiate this solution. The state, not simply depend on clinical parameters of lower limb edema and veins, etc., but to differentiate using dynamic parameters I have mentioned before, overfilled or underfilled. Overfilled, we can use diuretics, or underfilled, albumin and diuretics. These are guidelines to be used, and I will leave them to you, not run through this complex slide. You can find and read carefully. Coming to an important point, which is the diuretic resistance, which can be defined as failure to achieve a satisfactory clinical response despite a full dose of diuretics. And these are the causes behind this, including incorrect diagnosis, venous or lymphatic edema, non-adherence to recommended sodium or fluid restriction, which is common in our practice, drugs not reaching the kidney, non-adherence, the dose is too low, not correct dose, or poor absorption, GIT, you are to consider GIT absorption, reduced diuretic secretion, tubular uptake, decreased the kidney flow, other causes of decreased GFR, and insufficient response, low GFR, decreased effective intravascular volume, and activation of renin-angiotensin system. I have mentioned for the braking phenomenon with excessive diuretic use. What to do in this case with diuretic resistance? These are our solutions or our weapons to 5, including combined oral and diuretic therapy. Combined oral diuretic therapy, intravenous drug administration if we are using oral, which is not expected to be the case. Hyponatremia to start infusion with high normal saline. In this case of hyponatremia may aid a diuretics in this case, and if Professor Saeed Khamis is with us, he will be happy for this point. He is one of the or speaking about this point many times. Use of baptans and the use of ultrafiltration or mechanical use of removal of fluids. 24-hour urine sodium is important to be used to differentiate that what to do is we are really in a case of diuretic resistance, or we need more and more increase for diuretic dose. So assess natriuresis and weight gain. Exclude non-adherence, dietary restriction, exclude use of non-steroidals and other drugs. If no, measure 24-hour urine sodium. If less than 120 millimole per day, you can increase the dose of diuretics to maximum. If it is more than 120 millimole per day, you are expecting that you are giving the maximum dose. Dietary counseling needed, check his diet. Excess extracellular volume persists, and at this time, you are to go to add metolazone 5 to 10 milligrams per day, combined diuretic therapy. And the combined oral therapy is with the use of thiazides, metolazone, which results in weight loss, congestive symptom release, ejection fraction improvement, improved the quality of life, aerial hospital discharge, less hospital readmission, but unfortunately not that effect on mortality in all of these mentioned trials. So the American Heart Association guidelines recommended in 2018 stated that use of combined diuretic therapy in a heart failure patient with considerable fluid overload refractory to optimize dose of loop diuretics in monotherapy, at least reaching 160 to 320 milligram per day of furosemide, or of intravenous infusion, or as a continuous infusion of level C recommendation. If you reach this dose, for bolus or infusion, no response, go to combined diuretic therapy using of metolazone. The question is intermittent or bolus or continuous, or intermittent or infusion. These are the advantages of intermittent therapy, or disadvantages: severe kidney hypoperfusion going up and downs, imbalance of vascular filling, rapid fluctuation in natriuresis, post-diuretic congestion rebound. While continuous infusion is better regarding inducing diuresis and reducing natriuretic peptide. And let me go to this review article or systematic review about the continuous, published in Anesthesia Journal 2018. Continuous infusion versus intermittent bolus injection of furosemide in acute decompensated heart failure. They studied many studies regarding urine, regarding body weight change, which was significant, regarding in hospital stay, which was insignificant, and regarding all-cause mortality also was non-significant difference. And they stated that no difference were found between continuous and intermittent loop diuretic regimens in all-cause mortality, length of hospital stay, and electrolyte imbalance. Conversely, a significant improvement of diuretic effect, including weight loss, urine output, congestive symptoms, was evidenced by the continuous infusion of furosemide and the improvement of brain natriuretic peptide. You can use brain natriuretic peptide as a follow-up marker, not as a diagnostic marker, as I said in previously in the assessment. So improvement clinically on clinical parameters, including weight loss, urine output, and congestive symptoms. These are the bad news that I am approaching the end of my talk. So bad news for me, and I think good news for you. Ultrafiltration. What about the use of ultrafiltration? So continuous. So the question of continuous or intravenous, low or high dose, we address this, and the use of ultrafiltration is to be stated in the coming few slides. This is the mechanism of active ultrafiltration, and these are the advantages and disadvantages of loop diuretics and ultrafiltration. You can see that loop diuretics have direct neurohormonal activation, while isolated ultrafiltration, no direct neurohormonal activation. Elimination of hypotonic urine while removal of isotonic plasma water, not that much effect on electrolytes. Unpredictable elimination of sodium and water using loop diuretics, while you can control your fluid loss by ultrafiltration. Diuretic resistance is to be developed with prolonged administration of loop diuretics, and one of solutions, its solution is use of isolated ultrafiltration, which can be followed by restoration of diuretic responsiveness, risk of hypokalemia, hypomagnesemia. You can control your effect of ultrafiltration, peripheral venous access. No need for peripheral venous access. Here you need, of course, no need for anticoagulation, but here need for anticoagulation, no extracorporeal, and ultrafiltration need for extracorporeal circuits with all of its side effects. So comes the last question is diuretics or ultrafiltration, which of which? Of course, if we do not reach the point of diuretic resistance, if we reach this point, we are to consider ultrafiltration at this point. In New England Journal of Medicine, as usual, addressed this point in one of its big articles. You can see that this is the effect on weight loss, and this is the effect of creatinine increase. You can see that this is ultrafiltration, much weight loss, much weight loss or non-significant way than diuretics, while creatinine increase is observed mainly with ultrafiltration, not that case with diuretic therapy. These are the main two changes from baseline. This is serum creatinine. You can see that ultrafiltration, non-significant effect, but the effect at the last about 60 days and 30 days, both resulted in the change of serum creatinine, drop of serum creatinine, and the effect was significant by 60 days. And this is the change of body weight, decrease of body weight by both, and all through days up to 60 days, it was non-significant effect. That significant effect was found in cases of creatinine change. These are the side effects. You can see that ultrafiltration, any side effects, more side effects, patients in this study, more side effects with total patients with ultrafiltration, or number is nearly approaching. Heart failure more with ultrafiltration, other cardiovascular disorders, renal failure, somewhat approaching number, anemia or thrombocytopenia, catheter, electrolyte disorder, gastrointestinal hemorrhage, pneumonia, sepsis, all nearly approaching numbers of this patient. The endpoints, change of serum sodium and the change of only hemoglobin. All these were only significant in favor of ultrafiltration. This change in serum sodium in favor of ultrafiltration, while change of hemoglobin was in favor of pharmacological therapy. Only significant secondary endpoint between all studied endpoints. These are the all studies addressed this point, and you can see over up to this, and you can see, and they were collected in this meta-analysis, and you can see that many these merely are the conclusions of these studies. All agreed that fluid loss is greater with ultrafiltration group, reduction of length of hospital stay and readmission, greater weight loss, higher increase in creatinine somewhat, but no advantage of weight loss. Variability of results of all of these slides. Here, greater weight loss. Here is no change, advantage in weight. Here, fluid loss greater. Here, reduction of length of stay. No effect of length of stay. You can find that no clear recommendation in all of these studies about the difference between ultrafiltration and the use of diuretics. Of course, again, I am to repeat, not at the state of diuretic resistance. This meta-analysis stated that compared with diuretic-based regimens, ultrafiltration is more efficient in decongestion. Of course, patient with acute decompensated heart failure. It does not have a deleterious effect on renal function, not that as we can all imagine or expect. They can improve heart failure-related rehospitalization and without conferring survival benefits. No survival benefits. Symptomatic improvement, questionable effect on heart failure-related rehospitalization rates. Again, this meta-analysis, published in 220 in heart failure reviews, found that greater fluid removal and weight loss, lower incidence of worsening heart failure, lower incidence of rehospitalization, no difference in renal impairment between use of arterial filtration and use of loop diuretics. So don't be afraid of your kidneys, about your kidneys when you use arterial filtration as a method to decongest your patient and improve her clinical status. It is safe and effective treatment option for volume overloaded heart failure patients. These guidelines also no clear recommendation. European Society of Cardiology may be considered in refractory heart failure. Level evidence B. American College of Cardiology, American Heart Association, they stated that may be considered, not stated about it. Canadian, not recommended at all. Japanese, in patients with renal dysfunction and refractory condition, receive CRRT, all modalities equally effective. No guidelines for European Renal Association, dialysis, transplant, etc. No guidelines for heart. So guidelines are even variable to give a conclusion for this part. So my conclusion, Mr. Chairman and dear attendees and our colleagues and my dear colleagues, unnecessary intravascular filling is as injurious as enteral filling. So please avoid unnecessary volume overload. Proper assessment of fluid status is important using clinical methods and other radiological available methods and dynamic status and dynamic parameters. Crystalloids are the main players in resuscitation. Please remember use of colloids in certain sink only. And when we use crystalloids, please remember balanced crystalloids. Proper monitoring while filling is of extreme importance using dynamic parameters. Please avoid CVP and avoid static parameters. Loop diuretics in cases of volume overload. Diuretic infusion can give better clinical improvement, not prognostic improvement, that IV bolus infusion. Combined oral therapy, please remember this as a great tool when facing diuretic resistance with using thiazide-like diuretic metolazone. No evidence that favors arterial filtration over diuretic use in volume overload patients with or without acute kidney injury in terms of less progression of AKI, improve the clinical outcome or reduced incidence of AKI. Improvement of symptoms, congestion with possible lower rehospitalization rate is observed with the use of arterial filtration over diuretic therapy. Thank you very much.
Thank you so much, Professor Yasser, for this fantastic presentation. I just have a quick question, then I will let you to try to address or answer some of the attendees' questions. Sometimes volume assessment is very tricky, especially in patients with severe hypoalbuminemia because of nephrotic syndrome, or patient with liver disease, with portal hypertension. So can you tell us exactly what is the gold standard, what is the best method, clinical, radiological with a focus, or invasive, non-invasive tool to assess the precise volume status, especially in patients with interstitial fluid accumulation, and they might have intravascular volume depletion because of severe hypoalbuminemia or because of increase in the hydrostatic pressure. Please unmute yourself, Dr. Yasser.
Thank you, Professor Al. Can you hear me like
Yeah.
this? Okay, thank you. I think we are not to depend on single measurement. We are to depend on multiple measurements, including clinical presentation, including the clinical status of the patient, assessment of IVC, assessment of echocardiographic parameters, and the response, the dynamic response to fluid status, fluid challenge is very important in this case. What about this patient? How can he behave on giving him a bolus of fluids? Is there marked change in these dynamic parameters or no change? That means that the patient is under full. So I cannot recommend a single measurement that I can say to audiences, please go with this measurement and avoid all other measurements, but combine measurements is essential, and we cannot ignore, of course, the importance of clinical assessment and the importance of clinical assessment of our patient in this status. What about our patient? Is he orthopnic? Is status of his response to regarding fluid challenge. Even what I said is CVP, but you can imagine a patient without any cardiac condition and simply hypovolemic shock. If this patient CVP changes to the positive side with fluid bolus, it can give us an idea. It can give us an idea, not to recommend to use, but can give us idea how do this patient behave with IV fluid intake. So I cannot recommend one measurement. You can depend on available measurement to assess the patient properly, which is really difficult to assess. Assessment of volume overload, especially in complex ICU patients, septic patient, or something like this, is very complex and needs careful assessment using all our present tools.
Thank you so much. Can you please comment on the capillary fill and the bioimpedance techniques?
What do you mean? Capillary filling you can use bedside. Simple test to assess what about the patient circulation, about simply the perfusion of this patient. This is a visible sign to perfusion. But about bioimpedance in acute settings, as I said, it is very difficult to use in cases of acute settings to measure the patient fat, water, and etc. But I mentioned this for you. What we use usually is what I really use usually is the use of radiological methods and assessment of clinical. Capillary fill measures one of the parameters that I use usually to assess the patient filling. So can I give it back to you, give you about your experience in use of bioimpedance in cases of acute setting?
As you said, it's very challenging in several patients. We used the bioimpedance technique even in dialysis patients.
Yes.
And also we use a microchip. Now you can place a microchip in the pulmonary artery and do remote evaluation to the wedge pulmonary artery pressure, the occlusive pulmonary artery pressure in these patients, especially patients with cardiorenal syndrome, the advanced cardiorenal syndrome prior to dialysis. And even on dialysis, I have several patients on hemodialysis and dialysis who has microchip that's placed by right side heart catheter, and it's very straightforward. They connect it remotely, and they can monitor the volume status of the patient, and they give us a report, or they call us if there is any sudden.
5 جنيه تروح بقى المره الثانيه حطها هنا عشان ما تنساش تسرق.
Dr. Kamal Okasha and Dr. Mustafa El Ferrari has questions, so if you can please unmute them. Dr. Kamal.
السلام عليكم ورحمة الله وبركاته. Dr. Yasser, very and very great discussion. It's just not a question, but this is just considered as a comment actually for some patient who started dialysis, basically cardiorenal patient is already, you can say cardiac and renal disease.
Professor Kamal, your sound is not your connection. Your connection, Professor Kamal. Can you hear us?
Very well. Can you hear me now?
Yes, yes.
Asking about those patients with cardiac syndrome who are still dependent on diuresis. They're dependent on diuresis, and they get sufficient urine output on intravenous, infusion or IV. However, they are not with oral loop like this. So what can we do for those patients, Dr. Yasser and Dr. Amr?
As I understand it, the patient is taking maximum dose of furosemide and combined with metolazone,
They pass
and,
your
and no response, and still congested. This is that. This is your comment or question, Professor Kamal?
question. Yeah.
Yes, I think the next coming step is to do use ultrafiltration for this patient. This is do you?
I think we have also, Professor Yasser, if you agree with me, we have to assess the sodium intake for this patient, because one of the
Yes.
major reason for resistance to loop diuretics is the patient non-adherence, either of course to the medicine, but more importantly to the sodium intake. And you can do this, as
Yes,
Professor
Professor.
Yasser said, by measuring the 24-hour urinary sodium. It's a very good test to reflect what the patient is taking. So if it is more than 120 milligram sodium excretion, this means that the patient is not compliant with the salt intake. So that's very important. Also adding, so on top of thiazide and loop diuretic, adding potassium sparing diuretic might help. And if we cannot control the volume status with all of these measures, as Professor Yasser said, I mean, head-to-head comparison, it's hard, but for some patients, there is no comparison. I mean, patients who are resilient or refractory to oral therapy, especially cardiorenal patients with advanced CKD, they need early either aquapheresis without dialysis, or if they have advanced CKD, they need early dialysis and ultrafiltration. By the way, there is honeymoon happen after you start this patient with advanced CKD on dialysis ultrafiltration, because
yes,
you
improvement
decongest
of diuretic
them,
resistance.
right?
Yes.
And the kidney function can improve partially, and the patient might be able to respond better with diuretic. Then you can keep them off dialysis for a while. So sometimes we start the dialysis early with ultrafiltration, then kidney function and heart function improve partially, and it will give a couple months or so for the patient to have a honeymoon without dialysis. Do you
Totally
agree
with you.
Professor?
Totally agree with you, Professor Amr. And I didn't mention the point of sodium intake. That the question of Professor Kamal was strictly that the patient had all measures, including diuretics, including maximum dose of furosemide, including combined oral therapy. But of course, it is very important. And as you said, in urine, so 24-hour urine sodium can be a good guide for us to address this point. The second point is the honeymoon period, with that we usually with improvement of kidney function, improvement of urine output with ultrafiltration, not as some of our colleagues زملائنا يتوقعوا ان ultrafiltration will lead to more and more hypoperfusion. No, this results, what is it does? Congestion is injurious. Congestion impairs the kidney perfusion. Congestion, improvement of congestion results in improvement of GFR, improvement of kidney condition, and this load on the kidney is resolved. This load of the kidney is resolved and expected to have a honeymoon period with ultrafiltration, avoiding the use of excessive ultrafiltration that can lead to more and more, of course, to kidney impairment.
Thank you so much, Professor Yasser. I think Dr. Hisham Said has a question. Then Dr.
Hello.
Hello.
I enjoyed Yasser, Dr. Yasser طبعا. Surely you are the expert in the field of critical care in Egypt and in Africa for sure, and you have a very long experience, more than 17 years in the field of critical care, and you are the pioneer here. I just want to comment, if you allow me for that. بعد إذنك يعني. First comment هو if you have a congestion, it depends on the congestion of the heart function. Is it the right ventricle or left ventricle or biventricular? So it depends on that. For example, if you have only pulmonary congestion with overload status and low ejection fraction of left ventricle, and you have a kidney hypoperfusion, at this point, ultrafiltration by the dialysis machine may worsen renal perfusion. but maybe as well creatinine increase, not only from dialysis, but from the dilutional effect of and concentration effect. But on the reverse, if you have more systemic congestion on the right ventricle, what's called the D-shaped part, which is allowing that the compression and the reversible Brenheim effect, compression from the right ventricle toward the left ventricle, making impossible filling of the left ventricle and sometimes lower cardiac output. So at that point, we have to decide what are the most filled ventricle. Is it the systemic venous congestion? At this stage, yes, ultrafiltration will improve the renal profile bidirectional. One from the inferior vena cava decongestion state and the renal vein decongestion, and the decongested right ventricle allowing the left ventricle to relax and have an end diastolic volume for increasing the cardiac output. So it's a dilemma how to do ultrafiltration and that it's worsening or not. The clinical renal profile, urine output later, and honeymoon state. But in most of patients, as you said perfectly, that many patients with ultrafiltration has improved and have some vacation from heavy doses of diuretic. On the other hand, my other comment on the critical acute kidney injury patients, all the studies, Japanese and others, had found that if you increase the ultrafiltration above 1.75 milli per kg per hour, very minute ultrafiltration, the mortality increased from organ ischemia. And if you lower than 1.25 milli per kg per hour, the patient as well will die from congestion. So very narrow window when you are treating patients with AKI and the volume overload status. So it seems that volume status is very critical for patients' life, especially in patients attributed for or suspended for or allowed for CRRT or dialysis. In all cases, we all agree that we have two arms. One arm is hypervolemia with high mortality, even in patients on the end-stage kidney disease, and the other arm, hypovolemia with higher risk of organ stunning at the stage. So the clinical judge is the main cornerstone. If you are using other for the dialysis machine, for example, hemocontrol in the PASCAR or FMSC, just to measure the hemoconcentration effected during hemodialysis with doubtful results. Some results say it's good and saving lives and saving control of the volume, and some results are not. Still, the clinical guide is the golden standard. Thank you very much.
Thank you so
Thank
much,
you,
Professor
Professor
Hisham Syed. And Dr. Mustafa El-Fairly, if somebody can unmute him, please go ahead, Dr. Mustafa.
Thank you for your eminent presentation, Professor Yasser, and your good moderation, Dr. Ram. My question regarding the last part of the presentation, the difference between ultrafiltration and the use of combination furosemide and metolazone. I think we here, especially in Egypt, have an underuse of the combination and go faster for the ultrafiltration. Do you agree with me or not? If we have, if we put the shadow toward the use of the combination of furosemide and metolazone, we can get a good challenge for the patient here in Egypt. This is the first question. The second question, there is a difference between furosemide use and torsemide between the patient with renal impairment in the efficacy of relieving congestion and improving the urine output. The last question regarding the percentage of volume overload, which is in minus out over body weight times by 100. I want to know the in and the out, the daily balance of the patient or the cumulative balance of the patient. And thank you.
Thank you, Dr. Mustafa, and thank you, Professor Hisham. Regarding the Professor Hisham comments about the difference between the left and right ventricles, eventually the right ventricle will result in systemic congestion and impairment of renal perfusion. It doesn't. I think it doesn't need the full-blown picture of right ventricular failure. This what can imagine. It doesn't need that congested neck veins and congested lower limb edema. Simply, this can be a parameter of measurement, ultrasonographic measurement on something like this. It usually impairs the renal perfusion and leads to the same story. What we should all consider is not only regarding this point, not only the forward function of the ventricles, but also diastolic dysfunction is important. And I think you mentioned it, Professor Hisham, within your speech. Diastolic dysfunction is important. Sometimes we found the full-blown picture with a good ejection fraction or good forward pumping of the heart, but simply this patient is in a state of diastolic heart failure, which can have the same effects. One by one.
That's called stiff ventricles, non-compliant stiff ventricles.
Yes. All heart failure with preserved ejection fraction. Regarding Dr. Mustafa questions, for me, I don't jump to ultrafiltration except using combination therapy of metolazone and furosemide. So it is not that uncommon, as you mentioned, unfortunately, but usually, and for our clinical practice in ICU and our colleagues in ICU, they usually go like this: maximum dose of furosemide, no response, go to combined oral therapy, metolazone, and then we think about other causes, diuretic resistance, salt intake, etc. And later on, ultrafiltration. The second question about, I think we have to depend more on daily fluid balance, as we usually take by day, but cumulative fluid balance is important. The third one or the middle one, I cannot remember. If Professor Amri can remember me with the middle question or second question of Dr. Mustafa.
Okay, we already have several other questions. Sorry, Dr. Sahir Omar Al-Tashab she has a question. Go ahead, please, Dr. Sahir.
Thank you, Dr. Am. Thank you, Dr. Yasser, for the very nice lecture. I want to ask you about, the Aquadex machine. It's a small machine. It's much less costly than the dialysis machine. Do you have any idea why it's not widely used? I think I didn't see it in any hospital, whether private or governmental, in Egypt. I don't know if you use it abroad in USA or in Europe or anywhere else. The Aquadex machine is $70, I think. It costs $70, and it does the job of the ultrafiltration. Any idea what the side effects of it is, or any idea of or does anybody has an experience with it, and why it's not widely used in Egypt?
I think we all have dialysis machines are easy accessible everywhere, and we can use. I don't have experience with this use. We use only the dialysis machine usually, or CRRT, which are widely available and used. So please, Professor Amri, if you have
yes, comments. Thank you so much, Dr. Yasser. Thank you, Dr. Sahir, for this nice question. Of course, we have aquapheresis machines. The most important thing with the aquapheresis machine is you don't need a central vein or a fistula or to place a tunnel catheter or whatever. You can use peripheral vein, so which is less invasive and less side effects, of course.
I think, Professor Am, you are speaking about the aquapheresis in plasma exchange?
No, just aquapheresis.
Yes,
aquapheresis without plasma exchange. You can remove water.
Ultrafiltration module is just it's an filtration module. It's
similar to
bedside. It's a bedside machine. Yeah.
Right.
Ultrafiltration. Similar to what we use in plasma exchange.
Okay. Right. Ultrafiltration using our machine, either the intermittent hemodialysis or CRRT machine, need probably a central line or a fistula. But the aquapheresis, just you can use peripheral vein. That's number one. Number two, the filter is much cheaper the process itself is much cheaper, and the hemodynamic stability is better, so you can do it. The problem is, as Professor Yasser mentioned, several studies didn't show any improvement in the solid outcome, no improvement in renal or patient survival. The only thing is shorter hospital stay. So if you want to get rid of the fluid very quick, you can do it. That's okay. And as we just discussed, sometimes it's very hard to compare two techniques or methods because the patient, it's very hard for even when you put patient in a study to compare, oral diuretic or IV diuretic to aquapheresis. Some patients who are refractory to all kinds of diuretics, they are eligible to use aquapheresis on or early ultrafiltration on. So these are two different spectrum. I don't compare, I don't see how can this happen in RCTs kind of, trials, but you have the judgment. If you see the patient is not responding to the standard diuretics, you can of course use these. You can remove a lot of fluids, 5, 6, 7 liters in a day. So that's much faster. You can do it for a day or two, much faster. However, you have to be minded that this doesn't really improve, kidney or patient outcome. We have a lot of other questions. Let's move on. Professor Yasser, if you can comment on use of albumin with diuretics in patients who are hypoalbuminemic in the hospital with volume overload.
Of course, in the surviving sepsis campaign, they recommended the use of albumin to the patient, or the patient received received good amount of intravenous fluids with no improvement. Hence, we can go to albumin at this point. Of course, with patients with hypoalbuminemia. But you know that the hazards effects of albumin of use and the increased rate of mortality with use in critically ill patients, this is behind the restriction of albumin use in certain situations. In cases of severe hypoalbuminemia, this results in intravascular filling and more fluids in extravascular space. Of course, this can help, and this will reach us to the point of using fluids, more and more fluids with no response, and this will give us again to this point of using albumin in addition to in fluid resuscitation. Going simply that this patient is underfilled, similar to the patient of nephrotic syndrome. This patient, in this case, you can use albumin and can give some sort of diuresis. But I think albumin is not to take this major part in critically ill patient due to bad effects, especially except in certain situations of difficult resuscitation without albumin, and the real need of albumin both clinically and regarding resuscitation and all the filling status of the patient. I cannot recommend using albumin in all cases, jumping to use albumin, but cautious use of albumin in certain cases and personalized cases.
If you allow me, Professor Yasser, each 1 gram of albumin can have 18 milli of water from interstitium. So
Yes.
if you calculate that, if you have a huge edema, even 100 gram of 100 milli of albumin bottle with 20 gram just will have more in the circulation, 300 milli or 400 milli of
Yes.
water.
What
So its effect is very low.
Yes, of course, and we are not to ignore the bad effect or the mortality effect of using serum albumin in critical care settings to be used in all situations and depending on it in resuscitation every now and then.
And by the way, of course, Professor Yasser is talking about at least 25% of albumin, not the 5%, just to conserve the amount of fluid you're giving. So you give concentrated albumin rather than the 5%.
No, not
Other
5%.
question, Professor Yasser, for you also is use of albumin with ultrafiltration to augment the ultrafiltration and improve hemodynamics.
For my knowledge, except in certain cases, albumin is needed really. I cannot recommend using albumin to improve just simply the ultrafiltration. If the patient is overfilled, he will ultrafiltrate properly without the use of albumin. If you have another opinion, Professor Amr, can you share with us?
I completely agree. I mean, I reserve it for patients with severe hypoalbuminemia and
of course.
hemodynamic instability.
Of course.
However, by the way, as Dr. Yasser mentioned, RCTs didn't show any impact of using albumin in the ICU settings. The only condition that has showed some improvement in the outcome measures is patients with spontaneous bacterial peritonitis. So SBP is the only condition that showed improvement in outcome using the albumin infusion. Do you agree with that, Dr. Yasser?
Yes, totally agree with you, Professor Amr, and I don't recommend to rush to use albumin every now and then in critical care settings.
Very good.
Continue.
Professor
Okay.
Kamal?
Patient, yes.
Dr. Muhammad Abdelhamid wants to comment, please.
Assalamu alaikum. To answer my question is what's going after diuretic response? Good diuretic response with high dose of furosemide and metolazone. How to withdraw the diuretic effect? This is my first. My second is how to manage the fluid resuscitation. Is it 0 ml to ml or minus to get the response? If I go to be in negative balance, a patient may go to acute kidney injury, and so it will be sometimes it become a little bit dilemma.
The connection is not that good, Dr. Muhammad. So what I got is that you are asking about the balance between diuretic intake and if the patient
I will overuse سامعني حضرتك كويس دلوقتي؟ طيب حضرتك سامعني كويس؟
ممتاز يا دكتور عباري.
اتفضل.
يعني my question is هو نفس السؤال بتاع الدكتور عمرو التاني اللي هو ان how to withdraw from high dose to low dose to keep the patient in AO balance and the same time to keep it at AO balance, so you must give fluid resuscitation. Is it ml to ml or it is with minus?
هو في جدول انا يمكن ما عرفتوش هو ازاي الايكويفالنت الترانسفورم اوف بيشنت فروم اي في تو اورال تريتمنت. يمكن ابقى اشير مع حضراتكم يمكن على الجروب بعد كده. هو السؤال بتاع حضرتك اللي هو ازاي يعني البيشنت ده
from high dose to low dose after improvement.
يعني الامبروفمنت ما هو البيشنت يعني اون ديسشارج تو لو دوز وبعدين اورال تريتمنت نيدز اورال تريتمنت وذ امبروفمنت. فده انا هبقى اعرضه على حضراتكم، هجيبه واعرضه على حضراتكم دوز تو دوز. السؤال الثاني اوف كورس بروبر اسسمنت اوف فوليوم از نيدد، يعني ان انا ما اديش الاي في diuretics to the state that we reach hypovolemia and transfer the patient from hypervolemia to hypovolemia. This is an important issue and this needs careful monitoring and continuous monitoring in ICU critical care settings. The patient should be monitored not to be transferred from hypervolemia to hypovolemia. And if we reach this point, in addition to dehydration and bad effects, loss of the diuretic dose effect will be observed at this point, early at this point, even before reaching the full-blown picture of dehydration. What can I say, as you know?
Thank you so much. Let's move on because we have several other questions. One of the questions you need to address, Professor Yasser, is the cutoff point when you stop the metolazone and what level of GFR you can use thiazide diuretics and metolazone.
In lower doses of, in lower doses below 30, I use 5 milligram metolazone, and higher doses in higher dose stages of GFR. And if we found, usually the cutoff point depends on clinical improvement of this patient. The level or the period that patient is transferred from hypervolemia to normovolemia to hypovolemia, I think this is the area we are to decrease the dose of diuretics. decrease dose of loop diuretics and decrease our dependency on combined therapy to decrease the amount of diuretics. So proper assessment again is needed. If the patient is transferred from hyper to normal to hypovolemia, not to be done in this case, not to transfer the patient from normovolemia to hypovolemia. So at this stage, gradually decrease the need, depend on combined oral therapy, then decrease the dose of diuretics to reach the proper dose that adjusts the patient on normovolemic status, adjust the patient on normovolemic status, and transfer them to oral to discharge the patient.
Very good, very good. Thank you so much. Other comments, HRS. So I agree with everyone who mentioned HRS, use of albumin, of course, with octreotide and midodrine, but that's another topic. It's not really for, volume overload. Other things we need to address, please, if you can stop sharing, Professor Yasser, so I can give you some, try to answer or address a question that we mentioned at the beginning of the webinar. Thank you so much. So let's try to answer the questions quickly here. So you remember the first one, it's only one clinical case scenario, which is very common. We see every day a patient who came in with volume overload with combined kidney and heart problems, so low eGFR and low ejection fraction, now with volume overload, and he is on losartan, furosemide 40 milligram twice daily, atorvastatin, and he's diabetic on insulin, and he has, of course, signs of overload. And the question, what is the next step? You want to start IV furosemide infusion, or metolazone, or dapagliflozin, or start isolated ultrafiltration, or you would like to discontinue losartan. And I saw answers are distributed between all of these, but for this patient, we should really consider switching the oral to IV furosemide and give infusion. Start by giving good bolus dose, at least 80 milligram, then put the patient on at least 5 to 10 milligram per hour of IV furosemide, because the patient probably have severe gut edema and the patient is not responding to oral therapy because of the GI absorption. And this was done, and the patient, after 2 days of IV infusion of Lasix, he responded very well. And the other thing we need to address is, as Dr. Abdelbari said, what dose you want to send the patient home on. Do you want to give him 120 milligram twice a day of furosemide plus 10 milligram of metolazone, or would you like to put him on 80 milligram twice daily of furosemide? You remember he was on 40 milligram twice daily before admission, or you would like to give it the 160 milligram daily instead of in divided doses, or would you like to do the same for Biomix, either 4 milligram daily or 4 milligram twice daily? And the answer, the correct answer is to start furosemide infusion for the first question, and for the next question is to put him on 80 milligram twice daily of furosemide. As you know, volume overload is defined as excess total body sodium, not only the water, but also the sodium. So it's very important to assess the sodium intake. Volume overload characterizes several common disorders, especially in patients with kidney failure, heart failure, or liver failure, or of course with severe hypoalbuminemia and nephrotic syndrome patients. The specific pathophysiology of these diseases varies, but most patients present with one or more signs of or symptoms of hypertension, peripheral edema, pulmonary congestion, hypoxia, and ascites. Here, this is the reason, and Professor Yasser mentioned it very well. I just want to emphasize on one thing, on the hypoalbuminemia and the gut edema that happen consequently, because the majority of our patients with cardiorenal syndrome, they are hypoalbuminemic. They cannot absorb the albumin well, and of course other medication, including diuretics. They have gut edema, so they have nausea and vomiting and diarrhea, of course. So addressing the hypoalbuminemia chronically. I'm not talking about giving IV albumin, but improving their hypoalbuminemia is pivotal. Volume assessment is very important because I saw several times, occasions in my practice that patient with chronic lymphedema or venous stasis, they are over-diuresed, then they come in with acute kidney injury because they have intravascular volume depleted, but they have, because of the lymphedema, they have a lot of fluids in their legs. So please make sure that you're not over-diuresing a patient who is not really volume overloaded. The other thing is patients with advanced decompensated heart failure are usually associated with resistance to oral furosemide, and the best next step is to manage their diuretics with either good dose of oral or IV. However, the problem with the furosemide, and this is different from tyrosine or bumetanide, is the bioavailability of oral furosemide is low. It's about 50%. So, you can usually double the dose or sometimes triple the dose to achieve the best response. Furosemide could be changed to equivalent dose of Biomex and also of tyrosine. Metolazone could be added to improve the response of loop diuretic. However, loop diuretic, of course, is a stronger. Dapagliflozin have diuretic effect, and it improve the patient outcome in patient with CKD and also in patient with congestive heart failure. But in this acute settings in the hospital, you need to start IV diuretic infusion. Isolated ultrafiltration remove fluids in very good time, but it's associated with more frequent adverse events. The only good aspect of this, it can decrease the hospital stay. Of course, stopping losartan here is a very common mistake that majority of physicians do. Losartan helps to to decrease the afterload of the heart. It improves the cardiorenal syndrome, even if this patient has increase in his serum creatinine or a potassium of 5.2. You would like to keep ACE or ARBs and on top increase diuretics, and these diuretics are potassium-losing diuretics. So even if the patient has mild hyperkalemia, it's not a big deal. It might respond to increasing dose of IV furosemide. And now the patient is going home. How to change the IV to oral? So the patient, we can calculate how much, again, to answer Dr. Abdelbari's question, if the patient received 5 milligram per hour of furosemide, this means that he received 240 milligram of IV furosemide. Again, you decrease the dose because this patient already responded very well, making very good amount of urine. So I think 80 milligram of Lasix twice a day, which is equal to 160 milligram daily dose, should be enough. And the absorption is very important. So improving the serum albumin level, as we discussed, is important. We have to know that furosemide is completely metabolized in the kidney 100%, while tyrosine is metabolized mainly by the liver. Biomex or bumetanide is metabolized by both. Triamytrine is another good diuretic, but it needs activation in the liver, so it's contraindicated. It doesn't work in patients with advanced liver disease. And we have to know also the half-life of all the diuretic, because the peak serum concentration of loop diuretics occur usually within half an hour to 2 hours, especially in the furosemide. And I'm going to show you here that furosemide, the comparison and the equivalent doses of the diuretics that Professor Yasser would like to share. So, you have to know that furosemide is 50-50 bioavailability, while Biomex and tyrosine has much better bioavailability. So if you consider gut edema and poor absorption, you need either to switch oral furosemide to IV or switch furosemide to Biomix or torezumide. Thiazide diuretics has also better bioavailability compared to the furosemide. Equivalent dose of 1 milligram Biomix equal to 40 milligram of furosemide, equal to 20 milligram of torezumide, equal to 25 milligram of hydrochlorothiazide, and 12.5 milligram of chlorthalidone. By the way, chlorthalidone is longer acting, so you can give it daily, while hydrochlorothiazide usually we give it twice daily.
Please, Professor Amr, share this graph to the group chat, please. It's it's a fantastic, yeah.
Absolutely, Professor. The metabolism, it's very interesting. We don't have many drugs that are metabolized mainly by the kidney, but furosemide is one of those, so that's important. Biomix is metabolized 50-50 by the liver and the kidney, while torezumide is metabolized mainly in the liver. The rest are metabolized, hydrochlorothiazide and chlorthalidone also interestingly are metabolized by the kidney. So it's very important to know that furosemide, hydrochlorothiazide, chlorthalidone are mainly metabolized by the kidney. And here is the half-life. The shortest half-life is the Biomix, 1 hour. Then the furosemide is 1.5 hours to 2 hours. Torezumide is longer, a little bit longer acting, 3 to 4 hours. So you have to make sure that if you are using furosemide or Biomix, you use it at least twice a day, while torezumide, it can cover 16 hours to 20 hours, so you can use it. It's a longer acting. And as you see here, also chlorthalidone is very longer acting compared to the hydrochlorothiazide. And again, I'm going to share with you this slide in the groups. And here this is not my question. Actually, I borrowed this question from this American Journal of Kidney Disease core curriculum, very important. The core curriculum for volume overload was published last year. Please, if you have time or interest, go ahead and read this. It's just 5-6 pages, and it involves case discussion, very, very nice cases, so very good educational material. I really appreciate everyone's contribution.
Thank you, Professor Amr, for this stressing on the, again on this important points, pharmacokinetics, half-life, and etc. And I gave with Professor Hassan Shaisha, rahmatullah alayhi, complete talk on diuretics, including all of this information that I can give in another session in this platform, and we can discuss it, give it a long session to discuss all of these parameters that will I mentioned rapidly in this session. Thank you for stressing this point and giving this clinical example to highlight the most important point. Thank you very much. It was the best to close with this session.
Thank you so much, and I think we can stop by here. Just a couple of things we need to announce. First, I'm going to send all of you the recorded Zoom video within 30 minutes or so, hopefully less. And Dr. Yasser, if he allows us also to get his presentation, either PowerPoint or PDF format, this would be great. And of course, yes, Professor Hisham Said is going to share all of this information in his group. And thank you, everyone, and have a good night. Sorry to keep you late. And see you.
No, it's a great night as usual.
Thank you, Professor Am.
Yes, sir. Thank you so much.
Thank you.
Bye.
Thank you.
And excuse me to close this session. And as usual, announce. See you in the coming Wednesday. Thank you, Professor Amr, for moderating this session and sharing me. And thank you for all attendees, for all professors who shared, Professor Kamal Awkasha, Professor Shams Sayyid, Professor Faisal Shaheen, he was with us and but didn't comment this session. Thank you for all attendees for their very active session, which was